I'll get there.
And if you guys have any questions throughout the presentation, feel free to stick them in the chat and we'll make sure they're addressed, okay?
I love that. Can you guys hear me? Perfect. Well, we'll get started. I'm Dr. James Johnston. I'm with Sanford Orthopedics and Sports Medicine. I am your regional foot and ankle trauma guy and trauma surgery. I sit on a couple committees over at the hospital. Most importantly, surge operations, and on the MEC committee over at Sanford Aberdeen. Thank you guys for all that you do for us, and let's jump right into it. And so this is your June EMS webinar. It's June 24th and it's 7 o'clock. So we're going to be talking tonight about summer injuries, also known as summer trauma, also known as your summer drama. It's summertime, people are moving around, people are visiting our great state, and we like that happening, but there are people in the area that are in unfamiliar territories, and we just want to touch base a little bit about what some of the stuff that you guys might expect as far as the drama and the trauma going forward this summer. I have no disclosures, none to report for this particular talk. Summer trauma to look forward to, and most of these statistics are coming from the CDC, and it's over the last about 20 years, from 1999 to 2017 is where we're pulling a lot of this data. Summer represents the prime vacationing time, picnicking and other activities happening all over the country. With this increase, outdoor activities, people are in unfamiliar surroundings, and it increases the likelihood of injury. And July, this next month, is really where we see a spike in activity-related deaths. And we're going to try to talk about trauma deaths for this first part of this presentation. And just know, for every fatality, there is about a 30-fold serious disabling injury that occurs. And then there is about a 30,000-fold near misses, somebody that needs first aid, somebody that's going to need EMS services. So we're talking about United States in general, not just South Dakota. So these numbers are going to seem low, but then once you start hitting those multipliers, you guys see it. You guys know what is coming in during those days. So from 1999 to 2017, there were about 65 related fireworks deaths. Super fun. The guy in the bottom right here looks like he's about to have a good time, maybe do some fire juggling. I know that we've had some in the region in the last couple of years. And again, inexperience, mixing with alcohol, mixing with dehydration, I've been out in the sun all day, 65 related fireworks deaths, and then you can multiply that across the country. There's approximately 80 deaths from skateboarding, skiing, and snowboarding. Again, the kids are out there, they want to break out some new moves, and they end up landing on their heads or their spines, serious traumatic injuries. And again, it's a multiplier on that, and you guys will definitely see some of that this summer. 151 deaths from injuries suffered from diving or jumping into the water. This is a particularly fun one in the area because our lakes, a lot of the man-made lakes in the northeastern part of the state fluctuate so much, go up and down. So where you may have been able to dive off your boat or the second story of your pontoon, those things are rolling around out there too. One week, the next week, there may be a rock, there might be a foot and a half shallower, and a lot of injuries can occur in the water. 228 Americans have died from being struck by lightning. Again, lightning doesn't strike twice, but it's something that you need to be aware of, treating burns and fires related to the lightning strikes. 279 people dying from being stung by hornets, bees, and wasps. So take them seriously when they come in. There's lots of honeybees, lots of wasps out in this way. Out on the highway, we were kind of swarmed coming back from Mitchell the other day. So take care when you're out picnicking with your family and loved ones. And then other activities that pose even a greater risk during this time. There are 1,617 fatalities from watercraft and boating accidents in July alone over this 19-year period. And that's all sorts of motorized vehicles as they're rolling across the wakes. I know personally, when I'm out on the lake, it's a concern of mine of people trying to jump the wake from the pontoon or jump the wake from the speedboats, and people that are inexperienced riding wavecraft certainly can become problematic, and you guys will definitely see that this summer. And then just being outdoors can be dangerous. We've had a really hot June. I don't know if I ever remember having a June this hot. I grew up here and I remember rain days in June and having to bundle up. So heat exhaustion and people dying from heat exposure over the month. It will peak in the month of July. So outdoor track events I know have been going on lately, and just making sure that the public stays well hydrated and knows to the signs and symptoms of the heat exhaustion and heat stroke. And then if you guys aren't excited enough about the statistics we're throwing out here, there were about 8,179, it's 8 people, excuse me, in the US who either drowned in swimming pools or natural waterways, an average of 143 deaths annually in the month of June. I don't think that the water park in Aberdeen is quite as bad as the picture on the right here, but certainly we are a shortage for lifeguards in Brown County. And that's been kind of both at the YMCA and in the outdoor pool. And certainly that's going to affect the effectiveness of those lifeguards in involving you folks down the line. And last but certainly not least, we all know car accidents spike during the month of July. People again are traveling around. They don't know the area. They're away from home. They may be in a big city and they haven't been used to driving in the city. They may be coming to our city from someplace else, and you just have to be really careful when you're driving around in the summer months. People are on their phones even more today, and certainly distracted driving can be dangerous driving. So if that doesn't pique your interest, welcome to the meeting tonight. We're going to talk a little bit more about me and my practice and some of the stuff that I'm going to be able to see. Like I said, I'm Dr. James Johnston. I'm a board certified foot and ankle surgeon, certified in forefoot and reconstructive surgery here at Sanford Aberdeen. Everybody needs a little Dilbert in their life. And so this is the Dilbert for you for this evening. And it kind of encapsulates everything that we're going to be talking about: surviving family vacations and kind of being out of position. So things I'm going to look forward to. This is my summer trauma drama. I'm going to be seeing lots of foot and ankle fractures. I'm going to see lacerated tendons and torn Achilles. I'm going to see puncture wounds, ones that are caused by swimming in the lake, stepping on nails, stepping on glass, being out in the yard, working your garden. People working in the field right now, out there spraying, and then poolside. We're also going to see lots of ankle sprains and strains. We certainly see our share of burns, fireworks, pressure washers has been the big thing this week. We've had 3 pressure washer injuries. Thankfully, they've all been cold water pressure washing injuries. And then obviously grills. You know, when you're talking about foot and ankle, you're really talking about that grill tipping over in the wind, which certainly can happen, or a briquette falling down on their foot or stepping on a hot briquette. And then crutch injuries, we had a couple of those today, cars, ATVs, boat lifts, trailers. People are trying to get their stuff in the water and they're not paying attention. They slip, they fall, and they get rolled over on the lower extremity. Real quick, this is kind of the fun stuff. You know, you come in, they're dislocated there on the left, fracture dislocation. If you see something like that, you're out and about, go ahead and grab that big toe and just go ahead and slide that foot back up underneath that ankle. Get it close for me. When it's dislocated like that, certainly sitting on the neurovascular bundle, and that can cause ultimate damage down the line. On the right-hand side of the screen here, you're looking at a Liz Franck dislocation. So the midfoot is dislocated dorsally on the hind foot there. That's another one where the neurovascular structure is in danger or in peril. Go ahead and try to reduce that or try to get it in alignment. If you can't, we'll get it in the ED, and both of these would end up having to go to surgery at some point down the line. Tendon lacerations and rupture. This is a great T1 MRI. On the right-hand side there, you see the Achilles tendon, and that area coming down from the top, what you're seeing there is the intact Achilles tendon, and about 2 centimeters in that watershed area, you see that rupture. You see that kind of area where the Achilles is no longer attached to the calcaneus there, and that certainly can make somebody's summer kind of a bummer if you follow me. So ankle sprains, strains, people going to weddings, people rolling their ankles. You guys are certainly going to see your share of these, but these are coming into the clinic on a daily basis as well. burns and crush injuries. Now we're getting kind of into more you guys' territory, kind of where you guys get excited too. It can be toes, it can be forefoot, it can be the whole leg, it can be burn injuries where there's somebody decides to take a fire walk, somebody puts their foot on a radiator, or even hot water bottles during this time. They bring in the hot water bottle, they just want to get something like maybe they have a little hematoma. They're trying to get some breakdown or break up of that, and then they end up burning their skin. We had another one of these just this week come in, and it burned in 3 different spots on the leg. So now we're into wound care, and we have to go in and debride and kind of take things as they come to us, antibiotics, and make sure that the underlying injury is taken care of. Which brings us to today's topic. We're going to spend a little bit more time really talking about infectious complications of puncture wounds. And so these are sharp foreign objects that have pierced the bottom or the side of the body. And then what do we do with it? How do we treat it once you guys get them to us? And then I think we got a couple of the vignettes, some of the case studies at the end that we certainly will run through that also deal with this and kind of fall in your guys' arena. So infectious complications of puncture wounds. This particular wound right here is cat bites. And so you'll see them in multiple areas. We have both domestic and feral cats that will attack at some point. Dog attack too. I'm not beating up on the cat people here. But those puncture wounds really should be addressed. They should be opened up. They should be flushed out, and antibiotics should be started. Puncture wounds are any kind of penetrating wound caused by a pointed object. Let's just keep it simple. They are common injuries, particularly on the plantar surface of the foot, and they can be in other areas of the extremity, and they occur equally across all age groups. You know, nobody is immune to this. Nobody is really safe from the puncture wounds. Infections can range from mild soft tissue involvement all the way down to bone infection. The main complications result from the puncture wounds themselves, and you can have foreign bodies stuck in there, so it's always a really good idea of finding out exactly what went in there and what exactly did come out of there. That really helps us out on the backside. So the mechanism of injury, puncture wounds can occur from any broad array of occurrences. You can see some rusty nails here on the right side. That could be a kid that just runs into a wall and didn't see the nails. Puncture wounds on the sole of the foot from stepping on an object are most common. And you're talking about that forefoot area because that's really where you're putting a lot of your pressure down. The majority of the plantar wounds are due to nails. There's less commonly glass and wood, but imagine your own life, imagine your own kitchen. You drop a glass on the floor and you think you get out of it. I know I dropped a salsa bottle just the other day, and I came out 2 hours later after I thought I got all the glass, and there were still some pieces out in the front yard. And certainly my children are running around barefoot in the front yard, so that could have been really dangerous as far as puncture wounds have gone. Puncture wounds in the areas of the metatarsal phalangeal joints, that's really distal to the midfoot, are often deeper because we put our weight bearing surface there, and it penetrates that object even deeper in the lower extremity. You still get some heel involvement, but we're really seeing a lot of puncture wounds kind of out into the forefoot. People are barefoot, people are wearing Crocs, people are just dipping their toe in, and they're going to get some sort of injury kind of down the line. And we'll talk a little bit about what could happen if they do that. Though the one on the right here always kind of makes me cringe just a little bit, but I've seen that. I've also seen toothpicks in the end of the toe. We'll see glass up and under there, and it's just barely sticking out. And this can go on for a couple weeks. You think you get it all. I hope that one on the right doesn't go on for a couple weeks, but it does come in, quite often, still under the skin. They're worried about removing it. This is quite superficial and would be actually kind of fun to get out. So the incidence of infection following a puncture wound is really uncertain because a lot of these people don't seek immediate medical help. I mean, if you think about, especially in South Dakota, we're very independent people. We're going to rub a little dirt in it. Please don't have them rub dirt in it. But they're going to rub a little dirt in it. We're going to walk it off. So we don't really sure how many of these actually need medical attention until they actually need medical attention. As an example, in a survey of 200 general emergency departments, there were 44% reported in at least one prior plantar puncture before they came in for the current one. And of the 156 wounds that were actually reported, only 50% of them were brought to medical attention. That means that about 50% of us are just not showing up with these things. And they're turning out okay. Among the ones that were self-reported, and the infection rate was around 11%. When we talk about complications from trauma, open wounds, those type of things, in an actual healthy population, non-diabetic, non-smoker, we're really talking about 9% infection rate, 8 to 9%. And so if we kind of extrapolate that out, yes, these wounds are a little bit more dirty. They can certainly have tetanus. They can certainly have other bugs on it, especially when you start talking in and around that lake area. And so you're looking at about 11% infection rate, which would be higher than our normal trauma injuries or broken ankles or open fractures and those type of things. And it doesn't seem like 2% is a big deal, but when we're talking about surgery, 2% can be really the world. Other risk factors to think about when you do see these puncture wounds, people with diabetes are at a serious risk for infection following puncture wound, especially if their alpha A1C is above 8.0. Under 8.0, we think of them as a controlled or relatively controlled diabetic. Over 8.0, really think about those diabetics as being uncontrolled and at a higher risk for infection. There was a retrospective study of 114 patients, 83 of them who had diabetes. They found that the subsequent osteomyelitis, so this was not just a puncture wound, but a puncture wound that then went down to bone and created bone infection, was almost 40% versus 6.5% for the average Joe, or what we would consider a healthy individual. Again, we quoted you the 11% on the last page. Again, it might be underreported. Of these 144 patients, these are not superficial infections. These are not cellulitis. This is not redness in the extremity. This is where it actually went down and caused osteomyelitis, which is a big deal. That takes a long time to get actually into the bone. And once in the bone, our IV antibiotics aren't real great at removing the bone infection. We really have to do bone debridement at that point, amputations, and getting down and actually clearing out the bone using antibiotic cement once we get it in there. These patients were also more likely to require multiple operations and 14 times more likely to have a lower extremity amputated. Again, that's the diabetics are more likely to have the amputation. They're going to have complications with their blood flow. They're going to have complications with their wound healing. They're going to have complications with just being able to mount an immune response to that. In fact, only about 50% of diabetics will actually have a leukocytosis or an elevated white blood cell count during their hospitalization. Fevers and constitutional symptoms, fever, chills, nausea, vomiting, chest pain, shortness of breath is really a better indicator of how well that immune system is working and how that diabetic's going to go. I can't see, Michaela, can you see the chat board? Are there questions yet?
Nope, there's no questions.
Okay, perfect. Am I talking too fast? I'm a bit of a talker.
Nope, you're going good.
Okay, perfect. Other risk factors for infection following penetrating injury include the elderly, being older of age, and then wound contamination, obviously. Again, around here, we have all sorts of opportunity for contamination. We have our fields where our workers are out in on a daily basis. We have lots of animal pens and the beef plant locally, excuse me. And then we have lots of people in and around the lakes and picking up a lot of different contaminants. So it's not just your major players that you normally think of. It could be lots of different things that kind of have to think outside the box. So your basic microbiology players, it's a good segue into there. If you're just your standard basic injury, staph and strep are really the ones that we think about. The gram positives, and then you have the Pseudomonas. There's a couple papers, and we'll kind of present them a little bit, that there's Pseudomonas is actually when you have the object go through a tennis shoe or go through a boot. The Pseudomonas loves to live in the glue. It's counterintuitive, but it lives in the glue between the sole of the shoe and the actual shoe itself. And so that's why Pseudomonas is an uptick on puncture wounds. It's not living on the body. It's not normal. It is normal flora, but it's not living in that area except for that area of glue down there. And then water-based injuries. So you're talking about shells, glass in the lake, and the one I love around here are the fish hooks, because they're kind of fun to get out. You got your amoeba species, and then you've got some vibrio species and some microbacterium. And so if we know where that patient was or that person was and what they were into, it really helps dictate what we're going to do as far as antibiotics and taking care of them overall. These are just some really fun pictures. The one on the right, that is strep, and on the left is staph. We always like to know our enemy, and this is what they look like under an electron microscope. Also think about fungal organisms and other infectious plant organic materials. And then if it's a toothpick injury, which is a lot more common than you would think polymicrobial floral infections, oral floral infections, excuse me. And so we have to play that into it. Hopefully it's not still on the saliva. We always kind of give cats and dogs a bad rap, but human bites, as you guys know, are pretty dirty as well, or actually more dirty as well. Clinical features, the things that you guys are going to see out there: cellulitis, red, hot, swollen extremity. You'll look at the other one and it'll just be kind of doughy. You may be thinking DVT. You may be thinking, a Charcot incident if it's a diabetic. Soft tissue abscess, you'll be able to feel some fluctuance underneath the skin. I'll show you in a ultrasound here in a little bit. Septic arthritis, this really comes down to the patient refusing to move that joint. Once the infection gets in the joint, it's automatic. We got to go and flush it out. Tenosynovitis, it can come up tracts. And so if you have that puncture wound by the big toe kind of under there, it can track all the way back into the midfoot. And I've had to IND the middle of the heel to actually get rid of an abscess that started up by the hallux or in the first metatarsal phalangeal joint. Necrotizing soft tissue infection, neck fash. You guys have seen these things. They are nasty, and it takes a long time to set in. But once they set in, it really is life-threatening. The patient's septic, and it feels like Rice Krispies underneath the skin. It's that crepitus feeling, and the patient will let you know that they are in pain. And then ultimately, osteomyelitis in the extremity, you can't get deeper than bone, right? And so once it's in that bone, we're really talking about wide debridements, taking out any infected bone that we run into, replacing it with antibiotic cement, flushing it out multiple times, wound vacs over the top of it, and ultimately skin grafts, and then compromised osteostructure. And these things can go on not for days, but weeks and months of IV antibiotic care in order to get all these things out. And it's just because they're in that 50% of people that didn't seek the medical help right away and came in to see us. Totally preventable. So just some clinical pictures. The one on the left is just your basic cellulitis. You guys see this on a day-to-day basis. On the right, what you have there is a bone infection in the calcaneus there. So this is a T1 weighted image. What you can see there, the bones are all white, the tibia, the talus, and then the calcaneus, that heel bone, you see how there's that dark shadow going across, and there are two little cloaca at the front. There's two little spots that are little abscesses within the bone. The body's trying to wall that off, but it certainly is going to affect the entire bone. That's going to require a wide debridement, a possible partial calcanectomy, removing that bone from that area, and then the function of that foot really becomes hobbled for the rest of that patient's life. There's going to be purulence in there. There's going to be all sorts of purulence, and nastiness rolling out of there once you get deep down. On the left here, you have a neck fash. And so you can see the bubbling underneath the skin. It looks like soap bubbles underneath the foot, on top of the foot, running up the backside there along the Achilles and at the forefoot. And that point, you've pot committed to opening up all those planes and flushing all that out. If not, moving on to a below knee amputation, depending on what services you have and provided and what you can get to there. But that is a pretty wide excision that's flaying open or opening up every one of the compartments. that is going to ruin the rest of that person's summer. On the right here, this is an ultrasound of an abscess. You can see the 4 plus signs, the 1 and the 2, kind of marking the length and the width of it. It's sitting just above the IP joint in the toe, and you can see where that fluctuance is collecting, and then you can also see running kind of along that bone. There's also a hypercoagulability. There's also an area where it's probably disseminated a little bit into the soft tissue, and certainly that's going to require an IND either in the clinic or in the OR, depending on how large it is. We just had one of these the other day. It came from a puncture wound on the dorsum of the foot. He was on IV antibiotics for a couple days. The thing really presented itself, and we were able to do it bedside, and it turned out really well. But it was another thing just by being able to identify, length and width and where this thing's at and getting it treated appropriately. 2 studies of adults and children who are hospitalized for plantar puncture and wound infection. The mean time of presentation from the time the injury happened was 4 days later. So this isn't something that's going to happen right away. You're going to have that puncture wound. They're going to ignore it. It's going to be within that 50% that aren't coming in and seeing us. And though some of the patients did not present until several weeks later, even after that. So they walked around with this abscess on the top of their foot. They do Epsom salt soaks, which is great. And it can really cleanse, but you need to get those abscess drained out. You need to get those staph and strep and start them on empiric antibiotics before it kind of gets out of control to that neck fash. But it really, what I wanted to drive home with this was it's not right away. It's going to be several days, if not weeks later. The key to all this is taking a great history. We rely on our emergency department, who rely on you guys to know exactly what penetrated the lower extremity. Sometimes it'll be a toothpick, say, and they'll come in and they immediately want an x-ray. Well, a toothpick's not going to show up on x-ray. You might see the shadow of it, but really ultrasound is probably a better modality. And if you don't have ultrasound, then ordering an MRI and finding out if that object's still in there. It's a cost to the patient. Is it appropriate medically? I think sometimes grabbing those handheld MRIs, we have them at Sanford, we just kind of put it on there and we can actually see the object underneath the skin. That goes double for glass that's not leaded. There's not a ton of leaded glass left. But there's, in the old days, we could see it, 10 years ago. Now, so much of the glass is just kind of a shadow. You got to get good at reading shadows. The scene of the injury, where were they at? Were they at the lake? Were they in the field? Were they in the beef plant? Were they, down hanging out at the Mog? Again, I grew up in Aberdeen. I've swam across the Mog. I've jumped in the Mog to get my bike out of the Mog in the past. So those things are happening, and you guys will see it. The depth of the penetration, did it go through the epidermis, like that one we saw up there where it was just sticking under the epidermis? Did it actually penetrate the dermis? Did it go through the subcutaneous tissue? Did it penetrate muscle? And did it touch bone, or did it penetrate the bone? How deep did this thing go in it, into the lower extremity? Footwear at the time of injury. Again, we're worried about that pseudomonas if there is a glue on the bottom of it. Determining if the foreign body is still in the body. A lot of times patients will swear up and down, no, I pulled it out, or my wife pulled it out, or she thinks she pulled it out, and we'll go in there and there'll still be a big chunk kind of sticking in there. And then time elapsed in injury, again, 4 days to a week, you might end up seeing that cellulitis and the infection start. Medical history of the patient, we're really looking for smokers, elderly, and diabetics. Those are the questions that we ask when we get the phone call from the emergency department. And the other question is, has the patient ate? That's the one we're always interested. And then tetanus immunization history. We're going to give them a booster, right? It's not really a question if we're going to or not, but it's nice to know if they've been immunized in the last 10 years. I know all of us have, but we're preaching to the choir. There's some people will say 1974, and then you say, okay, let's bring them in and do the full boat. This is just a reminder, when you give a toxoid, when you give a booster, but you guys see this every day. So management, what are we going to do now that we have this patient coming in, they have a cellulitis? How are we going to deal with that patient once they're in-house? Foreign body removal, first and foremost, we're going to get whatever is in there out of there. Again, we use stuff like ultrasound, diagnostic ultrasound, we use MRIs, but really opening it up, following that soft tissue track down and exploring the wound thoroughly. It can take time and it can be difficult, but it's worth it in the end. Debridement and drainage, you have to explore soft tissue planes. You can't just have a one-track mind of trying to do it the smallest incision possible. Incisions heal side to side. That's a surgeon talking. So it doesn't really matter how long it is, but it really does. You have to get down and remove anything that doesn't belong there. Necrosis of soft tissue and bone. Antibiotic therapy, the minute they hit our door, we track how quickly we get our first generation cephalosporins. That's your ANCEPH into the patient's body. And if it's over an hour, we ding ourselves. The emergency department and we go to the trauma committee, and we actually penalize ourselves because that's something the state wants to know, but we actually track it in-house. In the plantar puncture wound infection, you're really looking at with the shoe, that is, you're looking at Pseudomonas. We're going to add ciprofloxacin to that because you're not going to be covered by your first generation cephalosporins. And then a non-plantar infection. So if this is a cat bite, or if this doesn't involve a shoe gear, you're really looking at staph and strep, and you're going to use cefazolin or ANCEPH on those wounds when they hit the door. And it's really a non-starter. If it's in the clinic, we might give them something IM, we will give them some orals, but really it's about timing and getting it into those wounds and kind of prophylactically getting the surrounding tissues around those wounds to kind of stop and have their Kevlar on, if you will, or their protective barrier. So debridement and drainage, this shows up. You're looking at this in the clinic and you're saying, I don't really know where this abscess is. I can see an entry point kind of right along with the third toe there. I can see the cellulitis. I can see it's tracking laterally, but it's difficult to kind of ascertain where this is at. I might start this on antibiotics. They tend to bring the swelling or bring the infection back to one spot, wherever the abscess is. I'll also use like I said, a diagnostic ultrasound. I'll also possibly get an MRI depending on the availability of the ultrasound at the time. And I'll see, where this abscess is and where I need to make my incision to be able to drain this out. Again, giving it antibiotics for a period of time is really helpful because if you're able to do that, then it kind of coalesces into one spot and you can drain it all out in one shot prior to it. But we don't always get the perfect hand. Diabetics, and so you have these little puncture wounds. This is actually a hand, but you have these little puncture wounds. You start seeing the vitiligo type almost looking of the lack of blood flow because this hand swells up so much. And then you have the area of abscess kind of above, and then below the area of necrosis on this patient. So on the right, you got your neck fascia. It comes in, and that's what ends up happening to the skin. It's mobile. The dermis is no longer intact. You got hypergranular tissue proximally, possibly exposed tendons, possibly exposed bone. You could be staring right at the tibia. And then on the left here, you have a puncture wound and then a nice big abscess right there next to the Achilles tendon. You can see the dark red into the pink, and you can see where the cellulitis is tracking up. They've marked it with a pen up the Achilles tendon, and the incision on that's going to have to be about 6 centimeters. You can't get around that. You're going to have to open that up and explore those planes. Hopefully it's not in the ankle. Hopefully it's not in the posterior joint. While you're in there debriding that, you can always tap the ankle and pull out fluid. If there's purulence in it, then you're obligated to go and wash out the joint. This is what a wide debridement looks like in the OR, and with just removing that necrotic tissue. We basically go until everything's bleeding, and we remove any necrosis, and it's on the back table. We'll consider reconstruction, amputation, secondary to trying to remove that. Again, you would use this more for like a neck fascia or a gangrene type infection. You wouldn't go just at that cellulitic patient and kind of open them up this way, but we want to make sure that we're getting all that non-viable necrotic tissue off of them on the first go around, and then we'll worry about flaps and reconstruction and skin grafts afterwards. After the debridement, the one on the far left there, you can see that, you're down to fascial planes. I mean, you basically took out all the necrosis. You're back down to everything's kind of bleeding. Some things are tendons, some things are ligaments, but you can actually get a really good result with this down the line. But again, this is a person that probably had a deep space infection. We let the abscess build up. And then it started tracking up that posterior tibial tendon. And so that's what you're looking at there is the inside of the ankle. One on the right, you can get, after the debridement, you pull it down. We try to keep that skin flap. If we can get that tissue to become granular, then we can flap their own skin, but they may end up losing it anyway. And then you see they have underlying fractures on top of having abscesses on the far right with metatarsals 2, 3, and 4, and 5 on that side. So it's going to be complex. It's going to be a long July, most of August to kind of get this foot back around into the right position. Wound backs, like I said, on the left. We really like these after our surgical debridement. Again, we'll also use antibiotic cement. We'll use a Benko powder directly into the wound. There's antibiotics in our flushing agent, in our lavage. And for a wound, an abscess about the size of a quarter, I will flush 3 liters. So a Mountain Dew 2.5 liters back into that wound, just that little space, to try to make it as clean as possible. Here at Sanford, we have this really cool technology called a VersaJet. And we're able to debride just necrotic tissue, and without taking good tissue, it selectively debrides. It's kind of like a high-speed water pick, and we're able to get it down to just the necrosis and be able to find anything that's tunneling. And it's a really good procedure. We are still doing about 90% of this with a skin blade or with a 15 blade, though. I don't want to mislead you and think that we're only using high-speed water picks. And then on the right, this is after a skin graft. And so we went all the way down. We were able to do that wide debridement. We had a large defect. We fill it in with the vac, and we come back over. We take the graft either from the thigh or from the back. We transport it down, and we're able to get nice closure over the top of that. But when you're a 22-year-old college kid and you don't really want to be spending the next 4 or 5 months surgically getting debrided over and over again on long-term IV antibiotics, and then ultimately getting your thigh cut into to cover up the hole in the side or the bottom of your foot, it's not a great summer for you there. So again, if you can encourage people to come in, it's much easier to kind of save these things up front. So in summary, and recommendation, puncture wounds and penetrating wounds are caused by sharp object. That kind of stands by itself. Puncture wounds on the sole of the foot from stepping on an object are most common. Risk factors for those infections include characteristics of the puncture wound, how deep it is, whether it's in the forefoot, whether it went through a shoe, the nature of the punctured object, is it contaminated, are there organic or vegetative materials in it, and then does the patient have comorbidities? Is the patient advanced age? Are they diabetic? Are they a smoker? Are they really the things that you want to look out for and kind of ask the questions about? The spectrum of infections and complications following the puncture wound includes cellulitis, soft tissue abscesses, and osteomyelitis, plus neck fash. And the most common cause of these are Staph aureus and streptococcus, or strep, excuse me. And common causes of wound infections after puncture include pseudomonas when isolated through a tennis shoe or through a plantar puncture through the shoe. And these can present several days, even weeks after the initial puncture wound to the lower extremity. So keys for you guys: key to identify risk factors, a key to identify what is actually in there, and it's key to notify or note other complicating factors. Foreign body should be removed in the patients who have a puncture wound, and regiment selective empiric antibiotics therapy for the puncture wound is based on what is the potential exposure, and then everybody gets tetanus prophylaxis once we've identified them. We just don't mess around with it. These are the references for the talk. Does anybody have questions?
And you can unmute yourself as well too if you have any questions that you want to ask.
I talked for so long, my mouse went to sleep, so that's good. That was a lot of me talking. Great. I did a great job.
Okay, with that, I'll pull up those case studies and we can walk through those maybe. Stop sharing. Okay. So can everyone see my screen? Okay, so we'll give a couple of minutes to read through this first one.
The very bottom right of the screen is blocked for me. I think
Okay.
it's whatever is on, there's
Yep.
like a black outline or something. So I think
Yep.
it's just probably our faces or something.
Yep, there you go. Okay.
Thank you.
Yep. Okay, if someone wants to say what you would do, feel free to unmute yourself or throw it in the chat and we can do that.
Can you hear me?
Yes. Yep.
Okay, what you'd want to do, at least where we are, because you're a ways from the hospital, you want to stabilize that and then transport if they're willing to let you, or encourage them to go seek further attention.
Great. Dr. Johnson or Johnston, do you have anything to add?
Yeah, so I like the obvious. So there's obvious deformity, and so often we get those X-rays, like I showed you in the presentation, where it's dislocated, right? Like it's not in good alignment. We'll believe you guys if you tell us there's a deformity. And so for this one, first his respiratory rate's up a little bit. I try to tell him take a deep breath and slow down. And then just pick up that big toe. And then there's all different ways that you can hold that deformity. It's going to be unstable. It's going to want to slip back down. But when you line up the second toe with the tibial tuberosity, you know that you're in alignment. And so that's really what you're looking for when you pick up that big toe, is that second toe, is that second ray in line where you have that Osgood-Slaughters type disease on the leg. If you're in alignment there and it looks alignment from the side and you're at 90 degrees, you guys did a great job. And when you come in, tell the ED provider, hey, there was obvious deformity. We believe you. And then we'll move on from there. And if there's obvious deformity, you're probably going to end up with a internal fixation. And so when we think of the ankle, we think of it as a ring. You can break a ring on one side and it's still really stable. You break a ring on two sides, it becomes unstable and it needs fixation.
Awesome. Okay, so the next one. So if someone wants to say what they would do, feel free.
I can give some input if nobody else is willing.
It looks like you'll be good. So yeah, you want to go?
I'm not trying to dominate this, but um, so if she's not willing to and refuses medical treatment, you want to encourage her of the dangers. Does she have any family members that maybe could come and calm her, talk to her, help the situation out? Because with everything going on here and what you're reading in her history, this could turn into a very serious situation. And if that dog attacked her once, what's to say it's not going to happen again when she goes to let it out or try to feed it? And at her age, she may not be able to fight it off, even if it is a little poodle. But if she's not willing to accept treatment, you can't force her, unfortunately. If there's no family members, maybe contact law enforcement to do a welfare check, or what is it, social services for the elderly. I guess I'm not overly familiar with. If the dog's going to be an issue, then that needs to probably be addressed.
Great. Dr. Johnson, do you have any comments to add?
Yeah, I love that. Thinking about our environment, think about where it's at. This is where a role, during COVID-19, we really had expanded telehealth. And so is there an opportunity here to be able to utilize telehealth through a family member, a neighbor? Again, at 74, technology is not always going to be readily available, but is there somebody that can get there with a smartphone? I have a couple concerns. Patient is a non-insulin dependent diabetic. And so again, going back to our talk tonight, these are the ones that are going to end up with systemic problems overwhelmingly, almost that 40%. Are going to end up with some sort of infection, whether it's cellulitis, needing medical attention. So I'm worried a little bit about that. She also has a sulfa allergy. So when we were picking our antibiotic, if this patient finally gets to me or is able to get to me, we have to be careful of those allergies. We're probably looking at some sort of clindative derivative at that point. But I would be very concerned not only about the dog and the environment, because certainly is this a safe environment for her to be in? So yes, social surfaces, but this person probably needs those wounds addressed given her systemic disease.
Great. Okay, we will do the final one. And any comments on this one?
This appears maybe more like a cautionary tale than a case study.
Yep, and that's what. Okay. So with that, let me stop sharing. Do you guys have any final questions for Dr. Johnston? Well, thank
Great.
you. Awesome. Thank you so much for presenting, and it was great information that we had today.
Yeah, I hope if nothing else, it was entertaining.
Great. Yep, it looks like the comments we have someone saying thank you for your time and information. And yeah, if you guys have any questions or anything that you have that come up later, feel free to shoot them to me and I can pass them on. As well as if you need anything with the EMS portal, feel free to throw it in the chat and I'll make sure Kyle gets the information for that, as well as making sure you guys can get credit for this if you did not register via the portal. So thank you very much, and we will call it a night.
Perfect. Thanks, guys.
Thank you.